We are going to continue on with our discussion of fluid and electrolytes, starting with part 2 here. So last week we talked about some general information about fluid and electrolyte balance. We talked about the normal distribution of fluid in the intracellular and the extracellular compartment. We talked about some variations or some imbalances in fluid and electrolyte status, starting with isotonic changes. So we looked at isotonic overhydration and isotonic dehydration. And we didn't get to changes in concentration, am I correct? So that's where we are now. So the first one we're going to look at here is hypernatremia or water deficit. This is where the body is more concentrated, and it may be because, well, the condition that we're going to look at is because you are deficient in water. Now, you can get this because you're either deficient in water, either you can't get access to water. We see this all the time in our elderly populations because they can't ask for water, may not be able to ask for water. They can't often get up and get it on their own, so they're waiting for somebody to bring fluids to them. So they're at high risk for this imbalance. Or it could be a loss of hypotonic solutes. So if we actually... so if this is what we talked about last week in terms of the concentration of what's lost. And I'm sorry, I've just copied this from the other slide and didn't modify it or not. So this was what was on the last week's slide, so talking about isotonic changes. But here now, if we're losing water or solution that is very dilute, so we're losing solutes, but we're also losing water, it's going to make us more concentrated, right? If we're losing solutions if we're having diarrhea, for example, that's very dilute, we're losing solutes, but we're losing more water, so that leaves our body more concentrated. Does that make sense? I'm sorry that that's confusing. So we should change isotonic really to hypertonic. That's where our body is going to be left. So whether we're left hypertonic or not depends upon the concentration of the fluid that's lost. So some of those secretions were listed on isotonic dehydration, but again, whether it's isotonic or makes us hypertonic just depends on the concentration of the fluids that are lost. So if we lose water, that's the best example here, or don't get enough water intake, then we're depleting our extracellular compartment, and we're making it more concentrated if we're losing more water than solutes. So here our osmolality has gone up to 300 from its normal, what we're saying is 280. So as a result of that, our sodium level appears to be higher. Now, it isn't necessarily that we have more sodium in our body, and in fact that rarely is the case. Typically what's happened is just that we've lost water and we've made those sodium ions look more concentrated. Okay? So your serum sodium level, when you look at that, you should kind of not even think about sodium. It's not really telling us about sodium level. It's telling us about water level in our body. That's really what it's reflecting for us. So in this case, we've lost fluid out of our extracellular compartment, both the vascular space and the interstitial space. We've made that area more concentrated. So what's going to happen to try to correct that? Water is going to move from the intracellular compartment, where it's more dilute, over to that extracellular compartment to try to even out those osmolalities. Okay? As a result of that, the cells in the the intracellular space, the cells themselves, shrivel up and don't work as well. They don't function properly because they're all shriveled up. Now, if your cells in your skin shrivel up, we don't care too much. If the cells even in your muscles shrivel up, we don't care too much. Where we care is that the cells in your brain shrivel up. And as a result of this, we have mental status changes. There's some shriveled up red blood cells. So Our extracellular compartment is depleted, and that has all the same signs and symptoms that we looked at last week when we looked at isotonic changes, where only the extracellular compartment was depleted. But so those same signs and symptoms will appear here because our extracellular compartment is low. But in addition, we'll begin to have signs of intracellular dehydration as well. And typically, what we're particularly aware of, we might see fever and thirst, but it's these mental status changes that we're most concerned about. And that's one of the key things that differentiates these conditions that we're talking about tonight from the ones we talked about last week, which were isotonic. Because with isotonic fluid changes, there is no shift of water into or out of the intracellular space, and so we don't have those mental status changes. Here we do. So how does our body compensate for this? How do we even make that shift? Well, one of the things that happens is because we've changed concentration, ADH is released. Remember, ADH causes us to retain water, and its primary job is to respond to changes in concentration. So since our osmolality went from 280 to 300, we're going to have a release of antidiuretic hormone. What does antidiuretic hormone do? It causes us to not pee. I like to call it the no pee hormone so I can remember what it does. So it causes us not to urinate, and as a result we retain water to make our extracellular space more dilute again, right? Now we're also going to have a reduction in secretion of BNP. That BNP, remember, is the hormone that's released primarily from the atria. It comes from other parts of the body too. When it's released, it causes us to excrete sodium and water. Well, here it's going to cause us to retain sodium and water to try to expand our volume again. We're also going to have activation of the renin-angiotensin system, which includes aldosterone secretion. So if you have that, you're going to retain sodium and water. So you're going to have less sodium and water excreted. You're going to have more of it retained. Okay, so you're going to retain sodium and water. Now with aldosterone, what do you lose in exchange for that? Potassium. Potassium. So you're retaining sodium and water, but you are losing potassium as well. So when we look at our lab values, the sodium level is going to be high here. When we're talking about hypernatremia or water deficit, we're volume depleted, but we're more concentrated. And because we're more concentrated, our sodium level appears to be high. And then because sodium and osmolality are related, the osmolality is going to be high as well. And then the BUN and the hematocrit can be elevated as well, just because the bloodstream is more concentrated. So the ideal treatment would be to reverse the underlying cause. So if the patient's having diarrhea and losing very dilute fluid, we want to interrupt that so that they're not losing that fluid. And then we can administer hypotonic solutions. Now if they're able to take water orally, that's great. Let's give them PO fluids, that would be fine. Or more commonly what we're doing is giving them some kind of IV solution, and we want to give them a hypotonic solution. So if we go back to our picture here and see that the concentration in the bloodstream is very high, so we want to dilute that, so we want to give hypotonic IV solutions. And I think there was a quiz question again that was wrong about that. So all of you that have emailed me about quiz questions, I'm going to go back and look at them and clarify those, and I'll make adjustments in the grades as necessary to correct that. Now, we explained last time why D5W is an a hypotonic solution. It's isotonic in the bag, but once the dextrose is metabolized, it has a hypotonic effect on the body. And then half or quarter normal saline, of course, are hypotonic, because normal saline is isotonic, so any concentration less than that would be hypotonic. Okay. Now that the last one that we looked at, hypernatremia or water deficit, that's pretty common. We see that a lot, especially in elderly people. When I used to work in the nursing home, we would always make extra rounds in the summer to administer fluids to patients because they weren't able to get up and get them on their own, so we had to deliver them to them, and that was the only way to do it. Now you could have hypernatremia in combination with overhydration. That's a little less common, but it can happen. And I have nothing against French fries, but you know, it's a good picture. So adding sodium would increase retention of water. So we see that all the time. People are taking in excess sodium and retaining water. So depending on the ratio of those two things, then we can end up with an increased serum osmolality, and then fluid would shift from the intracellular space to dilute that concentration in the extracellular compartment. So giving people hypertonic IV solutions can do this. Now, we don't typically give hypertonic IV solutions unless we're treating hyponatremia, but some other things are really concentrated, like feeding tube solutions are really concentrated. That's why we give free water to those people, so that they get a balance of concentrated intake and dilute intake. And then hyperaldosteronism, people that are secreting too much aldosterone because they have a tumor or something in their adrenal gland, or Cushing's syndrome, which also is an increase of aldosterone release. And we're going to talk about that when we get to endocrine. So those can cause more sodium and water retention as well. So for whatever reason we're adding both sodium and water, we end up with a more concentrated extracellular compartment, and in fact might be fluid overloaded. And then as a result of that, fluid will shift from the intracellular compartment to try to dilute that higher osmolality. Okay. So again, the cells would shrivel up, and we'd have exactly the same kinds of signs and symptoms. The same kinds of compensatory mechanisms, but you know, if the body can manage it to get rid of excess fluid, that's what it's going to try and do. So actually these are opposite of what was on the last slide. They're going to try and get rid of excess fluid if the body could do it. But if you have hyperaldosteronism, you can't get rid of sodium and water. That's what caused it in the first place. So again, the sodium and osmolality would be high, but here the BUN and the hematocrit might be low because you're overloaded, fluid overloaded, not fluid diluted. So it's helpful sometimes to look at the components of this, to look at what's the concentration doing and what's the volume status doing, and then add those together. Because people don't just have one or the other, they have combinations of problems. Yes, look at what the exact thing is happening. What is the concentration, and then what is the fluid status? If it's high, you're going to do one thing. If it's low, you're going to do another thing. Yep. Yes?
MCV increased?
Oh, thank you for mentioning that. When we switch over PowerPoints, I'm going to talk about that a little bit more. But here it wouldn't be changed because MCV is the volume that's inside a particular cell. Oh, so it could be decreased. Is that what you said?
I think that's what I meant, yeah.
Oh,
would that change, I guess?
Yes, because it's a cell just like any other. So if fluid is shifting out of the cells and the cells shrivel, then yes, the MCV might be decreased there. That wouldn't be a primary thing that I'd be looking for, but it could happen. But when we switch over, remind me to talk about MCV again, because a lot of you had questions about a quiz question related to that. All right. So here we're going to treat the underlying problem. In this case, we might give diuretics, where with the other one, the hypernatremia water deficit, we're probably not going to give diuretics. Here we might give diuretics to get rid of excess fluid. And then we might also give hypotonic solutions to dilute that high concentration that still exists. Now, we're probably not going to give them in the same volume that we would to somebody who had water deficit, but we might want to dilute their sodium level depending on what it is. Okay, then hyponatremia commonly is associated with water excess. So there are lots of causes of this. There are some psychiatric disorders where people just drink and drink and drink and drink and drink and get really dilute. There was a radio contest a few years ago. Do you remember hearing about that? Where they dared people to drink as much water as they could, and one woman drank so much water that she died because of this. Pardon? For a week? Oh, for a wee. Oh, to win a wee, yeah. So, yeah, she actually died because she drank so much water that she diluted her concentration so much that she actually died from that. So water intoxication from whatever cause. Giving hypotonic IV solutions to elderly patients who are less able to manage their concentration. That's a high risk. Tap water enemas, we don't do that too much anymore, and one of the reasons is because that water can get absorbed through the GI tract and change our concentration, so we're much less likely to do that these days. Flushing tubes and drains with water instead of normal saline. Now these days, people are switching to flushing tubes with water, NG tubes particularly, and you know, if somebody's on a tube feeding, that makes sense. You want to flush with water and administer extra water so that, because they're getting all that concentrated tube feeding. But otherwise, maybe there's new information that I don't have access to. But if we flush too much with free water, we can change people's concentration. So I think we have to be really cautious about that. SIADH, syndrome of inappropriate antidiuretic hormone. Now, that name doesn't tell you anything, so I like to think of it as syndrome of increased antidiuretic hormone, because that's what it is. So diabetes insipidus is too little ADH. SIADH is too much ADH. So if you have a whole bunch of ADH, what are you doing? You're retaining water and making yourself more dilute. And then renal failure, heart failure, liver failure, and again, those were on our slide last week when we were talking about isotonic overhydration. But whether it's isotonic or hypotonic just depends on the concentration of the fluid that's being retained. So in this example, we have an extracellular compartment that's overfilled, and it's so overfilled that the sodium level is diluted. So we have here in our example an osmolality of 260. So what's going to happen? Fluid is going to shift from the extracellular compartment into the intracellular compartment so that they even out their osmolality. And when that happens, the cells swell up and burst. Now, if they burst, they're permanently gone. On the other end, when they shrivel up, there is some hope that they might re-expand and be okay, but they may not. But either way, whether they're shriveled up or whether they're swollen and burst, they're not going to work very well. Now, the shriveled ones may recover, but these obviously are not. So here's a picture of those red blood cells and then the puffy ones over on this side that have swollen up. So here we see evidence of an expanded extracellular volume. And in addition, we have these same signs and symptoms on the intracellular side. Because it doesn't matter whether the cells shriveled up or whether they burst, either way, they're not working. And again, we're concerned about the cells in the brain. So we're going to have the same kinds of signs and symptoms. Here, the sodium level is going to be low because it's a reflection of our osmolality. We're more dilute. And then the BUN and hematocrit will also be low because we're more diluted up, diluted down, diluted out. Again, we want to look at the underlying cause. And here's when we look at a free water restriction. And you just have to check with your facility policy and see what they classify as free water. Certainly water, typically juices like apple juice or grape juice, because once the glucose that's in them dissolves, they're just water. Something like tomato juice often is not restricted. Broth, milk, those might not be restricted. So you need to know for your policy, are we talking about a total fluid restriction or just a free water restriction, and figuring out what that is. Certainly we don't want to give people anything that's going to dilute them more, so we're going to avoid those hypotonic IV solutions. Maybe diuretics because they're fluid overloaded. And here's a case where we might use hypertonic saline. There's 3% and even higher concentrations of saline available for people that have really low sodium levels. Have any of you given those? Graham, what was the sodium, do you know? Yeah. 1 teens? Uh-huh. Yeah. Okay, then the last combination that we might have, and again, this is less common, but hyponatremia. So our bloodstream is not very concentrated, but we're also dehydrated. So that can happen as well. Often it's associated with a severe sodium restriction. So if you're on a very low sodium diet, not taking in enough sodium, you're not retaining enough water even just to get by. Adrenal insufficiency, where you're not retaining sodium because your aldosterone is not working as well. Or if you're losing sodium because we're giving too many diuretics, or fluid losses that contain a lot of sodium. Any of those things can make us have a lower osmolality, so our bloodstream is more dilute, but it's not dilute because we added water, it's dilute because we lost sodium. So in our picture here, we have extracellular compartment that's depleted, but we also have a low sodium level and a low osmolality. So fluid is going to shift from the extracellular compartment into the intracellular compartment to try to even out the osmolality. And the signs and symptoms are going to be the same. And the labs here, the sodium and osmolality will be low because we're dilute, but our BUN and hematocrit might be high because we have less volume. Again, we're going to look at treating the underlying cause, restricting free water, and maybe, though, giving hypertonic sodium or saline to try to replenish that lower sodium level. Now, before we look at this one, let me just say I was teaching clinical with the undergraduates this spring, and we had a patient who came in with a glucose of 12, which is pretty impressive in and of itself, and a sodium level of, I think, 112. And I was just like, really? How's the patient doing? And the patient was recovering, happened to be an alcoholic patient who had all kinds of physiologic abnormalities. But what was interesting was the medics, the family called the medics, and the medics came and assessed him and assessed his glucose level, and then the documentation read like this: glucose level 12, administered 1 amp D5 or D50, administered 1 amp of D50, and gave a sandwich. And I'm like, how could he eat a sandwich with a glucose level of 12? But apparently he recovered enough from the D50 that he was able to actually eat a sandwich, come to the hospital, and then had this impressively low sodium level, but recovered okay from that without hypertonic saline. I mean, he did okay. So that was pretty interesting to see. Then the other extreme that I've seen is a patient who had, when my student took care of him, had a sodium level of 165. And so I was, again, is he alert and oriented? Is he on seizure precautions? What's happening? Oh, no, he's alert and oriented. Really? With a sodium of 165? Oh, yeah, he's alert and oriented. Okay, so we look back in his chart. He came in with a sodium of 185. And so at 165, he was doing great. You know, he was well on the way to recovery. But I had never seen either one of those extremes, so it was pretty impressive. I don't know, do you have extreme examples? No? Did I beat you? Okay, so you know our bodies are amazing in what they can recover from. One thing when we're adjusting people's sodium level is we typically want to go pretty slow, because if we rebound them too quickly, we can cause additional trauma to their brain. So slow adjustments there. Okay, just some thoughts about fluid and electrolyte replacement. One is always remembering the heart and how the patient's going to tolerate, looking at the rate and the volume of the administration, the fluid that's being replaced. And that there's a difference between maintenance and replacement fluids, so we might tank them up with something and then switch them over to some maintenance fluid that could be a different concentration, different solution, different rate, all of those things. Looking at the concentration of it, what the electrolytes are that we're giving the patient, what's being added to it, rate, and then the concerns about cerebral edema when we have too rapid shifts in sodium. Okay, we want to talk just quickly about electrolytes, and this is pretty dry stuff, but just to give you a big overview of some of these. So chloride, the thing about chloride is it primarily follows sodium. So if the sodium is high, the chloride is high. If the sodium's low, the chloride's low. That's typically what we see. There's various reasons to have either an increased or decreased chloride level. One thing, when we talk about acid-base, we'll talk about chloride replacement in acid-base imbalance, and how if we don't correct the chloride deficit, we're going to continue to have acid-base imbalance. So we'll talk about that a little bit later. Potassium, the main thing to think about with that is the resting membrane potential across the cell. And as the potassium shifts in and out, it allows us to have electrical activity, muscular contraction, conduction of electrical impulse in the heart. So if our potassium is out of whack, either too high or too low, we can have problems with all of those functions. So we see cardiac dysrhythmias, muscle weakness, those kinds of things. The other thing is we can see on the electrocardiogram changes in potassium level. Now the nice thing about this is if the potassium level is up, the T wave on the ECG is elevated. If the potassium level is low, the T wave is flat. So it's the one time when they kind of go together. If the level is up, the T wave is up. If the level is down, the T wave is down. So a little easier to remember. Calcium, also important in that stability of the membrane in terms of electrical impulse. It also is related to clotting. 50% of calcium in our bloodstream is ionized. That's the active portion that actually does the functions of calcium. And it's not bound to anything. So it's free, so it's able to act. If it's bound to something else, that's not the active portion. And the part that's bound is unionized, and I remember that by thinking about unionized. It's in union with something else. So the unionized is the bound part, and the ionized is the free part, okay? The active part. And you're familiar with Trousseau's sign and Chvostek's sign. I think I have pictures of those. So Trousseau's sign is putting a blood pressure cuff around the arm, and you can actually do it on the forearm. And you pump it up, and if you get a carpal pedal spasm, the calcium level is low. And Chvostek's is where you tap the facial nerve, and they get a cramp on that side of their face. Same thing. So we see low calcium levels often when we give blood transfusions, if there's a vitamin D deficiency, if we can't absorb fat, if we have alkalosis, and then these are the results of that. And this also, prolonged QT interval, is something that we see on the electrocardiogram, so we can see that evidence on there. And then hypercalcemia, a lot of times we see that in cancer patients, especially when they have metastasis. But there's a whole syndrome of things that go along with that where we have hypercalcemia. I'm going to tell you my calcium story. So have any of you donated platelets? No? So you can donate blood. You can also donate platelets, where they take your blood out of your body, send it through a pheresis machine, like we talked about a couple weeks ago, take the platelets off, and then return the rest of the blood to your body. Well, when they do that, the anticoagulant that they have in the machine binds to your calcium. So when you get the blood back, it's like you're hypocalcemic. Some patients tolerate that really well and other patients don't. And I used to donate platelets, but the first time I went and gave platelets, they kept asking me if I had any tingling, because, you know, hypocalcemia with those Chvostek's sign and the Trousseau sign, you also get tingling. And I said, no, I don't have any tingling, I'm just fine. And it takes a couple of hours to do that, so I sat through the treatment and did that. And at the end of the treatment, when she disconnected me and everything, I said, is there some machine in this building that kind of shakes the floor? She said, no, you're tingling. So my whole body was tingling, and I didn't know it. I was vibrating, and I thought it was some piece of equipment that was vibrating the floor, you know. So I continued to give platelets after that, thinking that I would either get used to it or it would go away. They would give me like half a bottle of Tums while I was sitting there trying to supplement my calcium. I got to the point where I was taking calcium supplements before I went in to donate, to try to build up my calcium before I got there. And it just never went away, and I would just feel yucky when I got done with it. It went away really fast, but I said, I'm done donating platelets. I can't do it anymore.
You're nice, you kept doing it.
Well, I thought maybe I would just develop a tolerance to it or something, and it would go away, but it didn't, so I quit. Yes?
I know in the ICU we check mostly ionized calcium.
Uh-huh.
We don't frequently check total calcium.
Uh-huh.
Is it different on the patients
No.
that are checked?
The ionized part is the part that's active and going to have an effect on the body. So that's really the part that's important. I think on the floors often we get a total calcium just because it's handy and comes out on the panel. And then if you really want to know, you want to check the ionized to find out what that is. Yeah. Okay, phosphate works in our intracellular space and produces ATP and 2,3-DPG. If it's low, we have various signs and symptoms. If it's high, we have, these are actually some causes of hyperphosphatemia. And again, tumor lysis syndrome is another malignancy-related syndrome that happens that can result in a high phosphate level. Magnesium, again, also important in conduction of the impulse for muscular contraction and also for electrocardiogram or for cardiac cell function. So we can see dysrhythmias here and also muscle weakness or tetany, depending on if it's high or low. Makes me feel cool in the summertime. Because I don't know where that is. Yeah. Oh, no.